Foundation in association with Project ECHO from the University of New Mexico. Again, these sessions are held on a weekly basis with various GI topics being covered on a rotational basis. So today we are having a lower GI endoscopy session, and we've got a presenter from Stellenbosch, Dr. Aslam Parker. And really the whole thought process behind today's topic is that I think it's a topic which is not all that uncommon, and it has caught out many endoscopists. And the key is it's actually, usually we pick up these rectal nets as an incidental finding. And often you're doing a colonoscopy, you see a little bump in the rectum, and decide to resect it because not being sure what it is. And a resection specimen comes back and you find out that it's a net. And I think it's not a difficult problem to manage, but the main issue is being able to recognize it. I think they occur probably a lot more commonly than we think. But really today's session is to create awareness to recognize these lesions. And I'm sure Dr. Parker is going to take us through a walkthrough of how to manage these patients and importantly, how to recognize them. So without further ado, I hand over to Aslam.
Thanks, Vikash. I'm going to share my screen now.
Just to note while he's sharing his screen, please post any questions you have in the chat. We will keep an eye and monitor any questions in the chat and try and address them at the end of the session. So please feel free to interact and post any questions that you might have.
Can everybody see me?
Yes, you're not sharing at the moment.
Okay. Okay, can everyone see?
Okay, it's coming up, but you've got it in presenter mode right now.
Can everyone else see presenter mode?
Yes,
Yes.
you just have to swap it over.
How do you do that?
Just end your slideshow and let's just go back in again.
Okay, it's ended.
Let's just do it again. There we go.
Okay.
I just put it in full screen. There we go. All good. You can continue.
Okay, it's not in presenter mode, eh?
No, it's not.
Okay, cool. Okay, okay, so I'm going to be doing a talk today on rectal nets. I'm from Stellenbosch University. There's a couple of very good papers that one can read afterwards. There's two papers in clinical endoscopy. The one is from 2022, looking at the endoscopic treatment for rectal neuroendocrine tumors. There's many methods to deal with this problem. And then there's a good paper on diagnosis and management of rectal neuroendocrine tumors as well in the journal. Then also there's an eNets paper that came out last year, which is the European Neuroendocrine Tumor Society. It's a good guidance paper on specific colorectal neuroendocrine tumors. And then there's a paper in Diagnostics on the diagnosis and management of rectal neuroendocrine tumors. So just some background, nets originate from heterogeneous neuroendocrine cells and peptidergic neurons. They exhibit various biological behaviors according to anatomical sites and pathological features. The number of rectal nets and related clinical research has increased during the last decades due to advancements in endoscopic technology. Also, we've been having better screening program, and then the SEER database has actually been picking it up quite a bit compared to over the last good couple of years. Big problem is that there is incomplete resection, as these lesions can often be mistaken for regular polyps. So the clinical presentation, they almost never present with classical carcinoid syndrome. They are incidentally found. The usual age is between 55 and 60, and then endoscopically they appear smooth, round polypoid lesions. They are almost always submucosal as well, and then they're usually found within 5 to 10 centimeters from the anal verge. The high-risk features may include subtle surface changes such as erosions or ulceration, and one really needs to have a high index of suspicion for these lesions. So also with clinical presentation, 79% are less than a centimeter, 5% are greater than 20 centimeters, and 89% are limited to the submucosa and are low-grade tumors. So just a review on the Paris classification, which we use for polyps. We have polypoid lesions and non-polypoid lesions. In our polypoid lesions, we have pedunculated lesions, semi-pedunculated, and sessile lesions. I think with our neuroendocrine tumors, we must just remember the overlying mucosa is often normal, and there won't be any sort of a pit pattern with a normal adenoma. I've added some examples over here. There's a very subtle lesion over here and here as well, but one can appreciate the normal overlying mucosa above the lesion. This one's a bit more obvious. And then here again, submucosal lesion. And over here as well, normal overlying mucosa. Not the best of images, but yeah. So most rectal nets are more indolent than other epithelial malignancies. Rectal nets are pathologically categorized according to the World Health Organization classification system, and the pathological grade is based on the mitotic and Ki-67 indices. Essentially, they're divided into low-grade, intermediate, and high-grade. Your low-grade tumors account for the vast majority at 88.1%, grade 2 at 8.2%, and your grade 3 at 3.5%. We also use the T&M classification for these lesions. I think the most important stuff here is the nodal mets and then the distant mets as well. And then as the lesions are going over a centimeter, the staging just gets worse. So the implications of the grading and staging, size does matter with these lesions. Size of more than a centimeter is a major parameter to determine the risk for metastatic disease in nets. In terms of lymph node mets, there's only about 2.5% when they're less than a centimeter, 12.8% when the lesion is between 1 and 2 centimeters, and then a 60 to 80% metastatic disease risk when it's more than 2 centimeters. So in terms of biomarkers, the most common immunohistochemical markers for neuroendocrine neoplasms are synaptophysin, chromogranin A, and neurospecific enolase. The most sensitive marker, however, for rectal nets is SAT-B2, which is positive in approximately 88% of rectal nets. It confirms a rectal origin in the case of metastases of occult origin as well. So there are various imaging modalities available. Rectal ultrasound, which may be EUS or radio ultrasound, MRI, CT, PET scans as well. But I think the imaging should really only be done in one of two scenarios. A tumor that's more than 1 centimeter or any grade net, which is 2 to 3. So your rectal ultrasound, which may be EUS or radio ultrasound, it's a good preoperative exam. It defines accurately the tumor size, depth of invasion, and it detects pararectal lymph nodes as well. EUS is really recommended, but not many have access to rectal EUS and radio EUS. So just some things on the picture over here. So if you were to go in endoscopically, you'd see really the tip of the iceberg and miss the lesion, which is going so deep there. And again here, you're sort of only seeing the tip of the iceberg. The lesion is going much deeper than you would see endoscopically. So your MRI and CT, your main usage is detection of local and regional spread. CT has limited value for the detection and characterization of regional metastatic lymph nodes in patients with rectal nets. MRI is considered as the most sensitive imaging method for regional lymph node detection. detection of residual disease after incomplete resection, and the involvement of pelvic structures in more advanced tumors. Then the ENETs actually recommend CT and MRI when lesions are greater than a centimeter. And then baseline local regional staging by pelvic MRI should be recommended in patients with rectal nets with a tumor size of a centimeter, or grade 2 to grade 3 rectal nets with suspected involvement of lymph nodes and EUS. And then in the lesions that have already been resected, it is the lesions with incomplete resection. And then also rectal nets with a tumor size of 5 to 10 millimeters and lymphovascular involvement or invasion of the muscularis propria. So PET scan, so the role of PET is mainly to assess the presence of metastatic spread or to assess eligibility of subsequent treatment lines in metastatic disease. Octreoscan is the first approved radiopharmaceutical for carcinoid tumor imaging. It consists of somatostatin analogs, radio-labeled with 111 indium, and used to detect somatostatin receptor-positive tissue. Most well to moderately differentiated nets retain high expression of somatostatin receptors and therefore can be studied by a 60A SSR PET, dotatate PET, dotatate PET, dotanoc PET CT, and they can be used for both primary and metastatic site detection. But I think, again, going back to imaging, it should really only be done when the tumor is more than a centimeter or any grade 2 to 3 net, rectal net. So this is quite a busy slide. I'm going to start as going through the treatment algorithm of patients with rectal neuroendocrine tumors. I'm going to start by, I'm going to go through the slide and then I'm going to just go through the management. So more than a 2 centimeter lesion, I think one needs to do imaging first. If there's metastatic disease, one would consider oncological surgical resection with follow-up investigations. I will give further information about the follow-up investigations when I've done explaining the algorithm. So then your lesions, which are 1 to 2 centimeters, again, imaging first. If there's no lymph nodes, then you can proceed to ESD or MR. If you have a complete resection, you would do some follow-up investigations. If you don't, you would then consider going to an oncological resection depending on your grade. And then the less than centimeter, I'm going to chat quite a bit about in the slide following. So from a practical point, EOS is recommended, but not many have access to rectal EOS and a radial EOS. So essentially for local staging, rectal EOS versus MRI. For distant disease, it would be MRI or PET CT. Then for grade 1 lesions with complete resection, no follow-up is needed. For your grade 2, grade 3 lesions and them being less than a centimeter, you would do 6 monthly abdominopelvic MRI and yearly sigmoidoscopy for at least 5 years. In addition, the recommendation from ENETs is to also do PET scan at the initially and then after 12 months as well. If you do manage to do an R node resection of a rectal net, which is grade 1 or grade 2, you would then proceed to do 6 monthly MRIs and yearly sigmoidoscopy for at least 5 years. In addition, also PET scan initially and after 12 months as well. For an R node resection of a grade 3, you would then do 3 monthly MRIs for 2 years, followed by 6 monthly MRIs for 5 years, and 6 monthly sigmoidoscopy for 2 years, followed by yearly endoscopic investigations for 5 years. And then again, also there's a recommendation of doing your PET scan initially and then after 12 months. And then in the management algorithm, when one is considering an oncological surgical resection, that would be either a low anterior resection or abdominoperineal resection combined with a total mesorectal excision depending on the localization in the rectum. So this will actually be quite a large part of the rest of the talk, and it's going to be the lesions that are less than a centimeter. These are often the lesions that we do encounter. There's various modalities which are available, and I'll go through them now. So your standard polypectomy for these less than a centimeter lesion has a high rate of incomplete resection, even if less than 5 millimeters and confined to the mucosa. EMR has variable rate of complete resection between 30 and 70%. And I think a lot of this is technique dependent, even with the lesions less than 5 millimeters. Endoscopically, ESD gives the best results. And then there's a couple of modified EMR techniques, which I'll go through. So in terms of data, this table looks at all the different studies from the year 2000, looking at different modalities of taking off these nets and comparing them. But just to summarize it, one can clearly see that polypectomy has the worst outcome in terms of resection. ESD has the best. EMR is inferior to ESD, and when using modified techniques, has a better rate of resection. So your first shot at resection is always the best shot. There's no real place for cold snare polypectomy. EMR is inferior to ESD. Modified EMR has similar outcomes to ESD from various studies in terms of resection. Over and under treatment is the big issue. It's not as easy to go back and get the lesion out when it's fibrosed. So a patient may end up over-treated with surgery, or when someone does a biopsy and you end up with the same outcome. So first shot at resection is always really the best. So there are various techniques, which I'll go through, especially, so this is your conventional EMR. I think in our setting, it's very reasonable and very practical to use. One should really try and use a big snare with a wide margin. The location is in the rectum, so it's a fairly safe area. But the big issue is people not getting enough deep tissue and not getting enough tissue. So this is where the technique plays a big role. Then one can do EMR with a cap. Essentially, you would suck the lesion into the cap and then snare the lesion at the bottom. And then you could do EMR with band ligation. A practical way of doing this is to take a G-scope and put your varicose band and suck the lesion into it and then band the lesion and then hot snare the lesion off. Here's just an example of that over here. The lesion was sucked in, band was applied and was resected. Then you have EMR after circumferential incision or pre-cutting. Yeah, essentially you're creating a space for your snare to go around to get under the lesion so that you don't leave any remnant. And here as well with the anchored snare tip EMR, it's essentially the same concept of trying to get under the lesion deep in the submucosas to not leave any remnant behind. Here you've got your conventional ESD for removal of these lesions. And then, so this is the end of my presentation. The take-home messages should be, there is a rising incidence of rectal nets. One should always have a high index of suspicion for these lesions. They are mostly submucosal lesions. And then for your sort of diminutive polyps, lift, have a big snare available with wide margins where you are suspecting these lesions. And then really there's no place for cold snare polypectomy. Modified EMR is ideal in polyps less than 1 centimeter or even a good technique EMR. For lesions 1 to 2 centimeters, don't intervene without any imaging, EOS or MRI. And if it's 2 centimeters, it's an absolute no-go zone for the endoscopist. And then really don't over-investigate when lesions are less than a centimeter. Your first shot is always your best shot. If you recognize and you don't feel comfortable, it's okay to refer the patient on. Vikash, you need to unmute.
Sorry. Thanks, Islam, for that overview. Just a few comments from my side, but before we get to the comments, I think let's just handle the one question that was in the chat. I think it has been kind of answered. So basically, I think the key to these lesions is recognition and awareness. And the whole issue is that often these lesions go unrecognized, and what they often just look like, and I often get a call and say, it looked like a little pimple in the rectum. So I just decided to put a snare around it, and invariably it's going to be a cold snare because usually these lesions are small, like you showed, the majority of them are going to be less than a centimeter. And then you can get the specimen back, which shows an incomplete resection margin on your histology specimen. So the idea is to recognize them, because not recognizing them leads to either over or under treatment. Under treatment, you take it out with a cold snare, you don't get it all out, and then you're left with a lot of questions. What to do next? It's now fibrotic. I didn't put it there too. Am I going to find the site? Do I need to scan? And then the other issue then becomes over treatment, because now it's fibrotic and might be difficult to go and re-resect. You end up sending your patient for treatment, which is probably not necessary, a therapy like surgery or more invasive therapy. So you end up having quite a bit of resource limitation, constraints on your system. And a lot of these lesions also then become over-investigated. And we find often that people do yearly scans and yearly dotates for these small, less than 10 millimeter lesions. And really, if you resect them well, they are indolent. So the key is to recognize them endoscopically. And the endoscopic features essentially is what you said. And the idea is to recognize that it's submucosal. So the small ones less than 10 millimeters are mostly going to be submucosal. The larger ones can erode through the surface of the mucosa. But what you're looking for is a regular vascular pattern. So you want to compare it. And if you're not sure what the regular vascular pattern is, just put your scope and image the area next to your polyp and then look at the area over the polyp. And if it looks the same, that's a regular mucosal pattern. So most of the time they have a slightly yellowish tinge. So they're a small little bump. They tend to be Paris 2A, not very sessile, and have a yellowish tinge, but you'll find regular round pit pattern on them. The pit pattern, the round pits might be slightly bigger than the round pits surrounding, but it's very regular and it will still be round. So recognizing that it's something subepithelial is really the key. The next thing you really want to do, and you want to be accurate, because as you mentioned, size matters with these lesions. So it's not about guesstimating and it looks like it's 4 millimeters, it looks like it's 9, because size really does dictate further management. So you want to accurately try and make an attempt to measure the lesion. And there's several ways to do that, but essentially what you want to do is use an instrument with a known size. So one of the easy ways to do that is to take a biopsy forceps, an open biopsy forceps. A regular one measures about 7 millimeters. Your jumbo biopsy forceps are a little bit larger. But you also want to make sure that the biopsy forceps is right against the mucosa. If the biopsy forceps is sitting against your lens and your scope is far away from the lesion, you're going to underestimate the size, because that biopsy forceps is going to look bigger. So you need to make sure that that forceps is right against the lesion. You can also use other things if you know the size of them. For example, most snare sheets, so I'm not talking about an open snare, I'm just talking about the white sheet. If you put that white sheet against the mucosa, most snare sheets measure about 2.4 millimeters. But again, you need to know the size of your snare sheet, and you can use that again as an estimate to the size. You can also use an open snare, but remember that snares are measured with width and not length. So you get various shape snares. Not all of them are round. So you need to know which size you're using. But if you're opening up a 10 millimeter snare and the lesion is 3 millimeters, it can be hard to guesstimate. So there, again, your biopsy forceps or your catheter sheet is going to be probably a more valuable tool. And you really do want to do it. So maybe I can ask you a question, or Aslam. I mean, you showed us data that showed that EMR does have a very, poor R0 resection rate. And you also told us that there's no role for imaging, or is in for the smaller lesions. And again, like you mentioned, the issue with EUS is that not all of us access to a radial probe, and it's very hard putting this 3 mm lesion against a linear probe and actually getting a good image. And it can be difficult then to determine what layer it's coming from and how deep it is. So even if you have access to EUS, it's better to have a radial probe rather than a linear probe. And I don't think anyone really has a high frequency probe that will give you 9 layers and give you a better description of how deep it is rather than our standard frequency probes. So I think histological staging is good enough for these small lesions. MRI is not going to be accurate enough to tell you how deep it is. But if, again, I think you drove an important message that if you're not comfortable resecting these lesions, then rather send them on to someone who is comfortable, because you showed us some data there with regards to the rate of complete resection with standard EMR. So the reason why Islam said there's no place for cold snare polypectomy is, remember, the cold snare doesn't get that deep. Usually cold snare only gets through the mucosa and not even the submucosa. Often when you do cold snare, you see a little white stalk after that. That stalk is usually bunched up muscularis mucosa or a little bit of submucosa. So that tells you that you're not getting deep into the submucosa with the cold snare. And by definition, we just mentioned that these lesions are subepithelial, so depth is important. So if you are going to use a snare, and I think, I mean, not everyone has access to ESD and some of these more fancy or modified EMR techniques. If you are going to use a snare, the saving grace is that these lesions are often very low in the rectum, like you said, 10 to 5 to 10 centimeters within the verge. And that's useful because in that area, you can be more aggressive. Even if you do have muscle injury, you're not going to cause issues. You can even leave the muscle injury alone. I mean, if you speak to the colorectal surgeons, they often do full thickness resections there and just leave it alone. And interventional endoscopists, we not too scared to go into intermuscular dissections low down there because it's quite safe. It's below the peritoneal reflection. So then I would say get a nice lift below the lesion and take a nice big snare and try and get your snare and it's about technique. So you showed a rate of 30 to 70%, and I think that drives the message that technique is probably the result in that variance. But you want to take a big snare and try and get that lesion out as deeply as you can. In terms of the modified techniques, you touched on some of them. There's so many different techniques available today. I mean, really, the world has become our oyster. There's so many techniques available. One of the modified techniques, which I think is a relatively good and easy technique to use, is using bands or ligation or EMR-L or band EMR, whatever you want to call it. People call it different things. You don't even need a dedicated banding device like your Duet system. You can simply take your variceal band ligations, pop it on the G-scope, and proceed to suck that lesion up into the cap, deploy your band. And the idea is to then cut below the band. So don't bend and cut above the band. The idea is for the band to be placed below the subepithelial lesion and then proceed with the band EMR. So that, I think, is something relatively easy to do and something relatively accessible. Other things like doing circumferential or pre-cut EMRs where you cut around. There's a whole lot of techniques. The one other technique that I think will come up, and I don't think there's any data for, but is probably going to come up, is underwater EMR. Underwater EMR is coming up for a whole lot of things. And the idea of underwater EMR is that you don't need to put a lift to expand the lesion. You can do hot fairly safely without a lift. And the idea is because when you put things underwater in the colon, what you tend to see is the mucosa creates these little folds, whereas the muscle layer maintains that circular ring. So you get that mucosa floating up, and that's where you get adequate depth. So there's no data for it, but I suspect underwater EMR is going to emerge as a technique. In the lesions that have been resected before and you have no margin, that becomes tricky, because sometimes it might be a 2-3 mm thing and you might not be able to find the site, number one, especially if you've done cold snare and you don't have a big scar. But also then re-resecting an area that's fibrotic does become, of course, more of a challenge. And you do have modified EMR techniques available, like pre-cut or hybrid ESDs. But one of the valuable tools in that kind of setting can also be a full thickness resection device. Now, the problem with full thickness resection device is you have to have a bit of experience with the device, number one. availability, number two. And number three, it's not actually funded by the funders, at least in South Africa. Medical aids don't cover it. And the device can be 15, 16, 17,000 rand. So it's a lot of money for the patient to pay. Again, over treatment. But it's a good option, resecting an area that's fibrotic. So I think it's a good endoscopic technique and can bail you out of trouble. But you do have to have a bit of experience with the device, because you can capture surrounding tissue or organs that you didn't want to capture, and then end up getting a urethra or something else in your specimen. Look in the rectum, that's not going to be likely, but you can capture surrounding structures there. So full thickness resection devices are quite useful in that instance. So yeah, lots of things to consider, but I think the key is to have a high index of suspicion and recognize them. And if you see a little submucosal lesion or something that doesn't look right, it looks yellow, but the surface looks fine, don't grab your cold snare. Rather, if you're not comfortable taking it out more deeper, rather send those lesions off, because it does become very tricky and becomes quite difficult to manage these patients when you don't have an adequate margin on your resection specimen, and then subject your patient to a whole lot more procedures and invasiveness. So, and these lesions, I think, are probably a lot more common. I think the reason why the SEER data showed an increase is not because they increase, it's because we're actually starting to identify them with high definition scopes, routine retroflexion in the rectum, and better imaging quality. So it's probably not that they're becoming more common, we're probably just finding them more. And even with that, I'm pretty sure we're missing a whole lot more of them. And I think that just also is further evidence that they are probably more indolent than we think. You showed a lymph node metastasis rate of less than 2.5%, but it's probably less than that, because how many have we not found that have not caused any issues? So I think they are quite indolent lesions. And again, key is recognition. Prof, would you like to comment or add anything? Or
Yeah, so I'm quite interested. Obviously, they're very rarely syndromic, but do you recommend, what tests do you actually recommend to ensure that they aren't syndromic, or is a history just enough? Or should you be doing other things? Obviously, if these were upper gastrointestinal or pancreatic neuroendocrine tumors, the approach would be slightly different. So do you need to investigate them for syndromic syndromes?
I don't think you do. Look, they are found incidentally. Almost never were there symptoms, and I think what they produce doesn't really give you some symptoms, like as a typical other carcinoids would.
Yes, I don't think they're called carcinoids now. I think
No,
that's
they're not. But I'm saying like our usual typical carcinoid syndrome, they don't fit that mold at all.
yes, but I think there are other syndromic.
Yeah,
There are other syndromic things that
yeah,
do occur, because they are somatostatin positive, aren't they?
they are receptor
They have a
positive.
host of potential neuroendocrine functions.
Mm.
But yes, and
Yeah,
the other essence, again, I mean, I know not many people are really doing ESD in this country, and generally in Europe, not so much. It's gaining traction, obviously, in a variety of settings. But my question really is for Vikash. If you see these, is it a bit like seeing a complex polyp? If you recognize that it's submucosal, then surely you should take a decent picture of it and send it to someone who is doing these things on a regular basis, so that you can get the resection sorted out. So I'd be interested by a show of hands, if those of you who can go to the reaction, how many of you have actually dealt with a rectal neuroendocrine tumor, probably incidentally because you decided to take it off. So please, if anybody could just say, yes, I've seen one in the chat, or put a hand up on the screen that we've got in front of us, the gallery we've got in front of us. So I see 2 hands so far.
just to add to that conversation, and of course, I do have referral bias, but in the last 2 months, I've had essentially 2 of them referred, which were incidentally picked up. And again, the classic scenario of I saw a little polyp in the rectum. I put a snare around it, and surprise, it came back as a as a rectal net. So not as uncommon as we think. I think, bro.
No, I think obviously better imaging and better prep and just better standard of endoscopy is bound to lead to more of them. But again, the natural history of these small ones is really difficult to know exactly what it is. And would you vary your approach depending on, say it was you found one of these in an 83-year-old lady and it was under a centimetre, what would you do with it? Perhaps I should ask the presenter. Would you leave it alone, or would your interventional bones decide that you must take it out because it's a lump?
It's under a centimeter. It's in a fairly safe area, and the size is quite small. So with a good technique EMR, you can probably take it off.
So is there any place for watchful waiting?
Not from what I've seen from the papers that I read.
Take them all out.
Well, but you first need to recognize it.
Yes, sure. Well,
If you're not recognizing it, then you won't be taking it out. Well, hopefully not.
well, and I mean, sorry, the other thing is there a differential diagnosis for these submucosal lesions? Could it be something else? You didn't really cover that, did you?
No, I didn't.
Is there?
There is a differential diagnosis for submucosal lesions.
Yeah.
Yeah.
What would it be? Surgeons usually know three things in the correct order. Physicians know
Like
random order. So do you know three?
lipomas.
Okay, yeah, right. They're also slightly yellow, aren't they?
They're also slightly yellow, so it can confuse you. Your cysts, but not in the rectum, I think. Yeah.
Any
And
others?
I'm going to give you three. So the other one is
That's
rectal
good.
net.
That's good. I like that.
Yeah.
What's the third?
I said the rectal net.
Oh, yeah. The
Cyst
and lipoma.
and the lipoma.
Oh, all right. There are a few others, I think.
Yes, there are.
Okay. Yes. So again, everything isn't a peanut that's in the rectum that is submucosal. So again, that's another reason that you should think about the natural history. I must admit, I don't think there's enough information about watchful waiting for these small neuroendocrine tumors, even in other areas of the tract, especially when you get to an elderly age. And that's the other thing that I thought was very aggressive was that your use of MRI as follow-up. That seemed phenomenally aggressive.
So that was
unsustainable in our environment.
So that is the recommendation in the guidelines from ENIT.
Yes.
And they've obviously based it on risk stratification. So it's the larger lesions, it's the lesions that based also on the grade of the lesion and the timing and things. I can understand that in our setting it may not be as cost effective, but that is the guideline recommendation. We don't have a recommendation for follow-up of these patients in South Africa.
Yeah. Okay.
Yeah, I mean, with regards to should you watchful waiting, I mean, certainly a good discussion with your patient and having your patient come in on the decision-making process is important there. But I mean, there's several arguments to make to and for it in terms of watchful waiting. Again, like you said, how do you know you're dealing with the net? Number one. Number two, how do you know what the grade is if you don't have histology and you don't have a specimen? So yes, if it's grade 1 and small, probably not going to do anything. But you're not going to know that unless you have histology. Third argument would be is that they low down in the rectum, 5 to 10 centimeters from the verge. Even if you are a little bit cowboyish with your snare, it's probably going to forgive you. I'm not saying you should be a cowboy with your snare, but it's probably going to forgive you. But then you got to weigh that up against the risk of bleeding, the risk, life expectancy of your patient's other comorbidities. So I think taking a rational approach and involving your patient in that decision-making process is important. It also depends very much on which center you are and your comfort and your skill, and you've got to weigh in a whole lot of factors when you're making that decision. And definitely include your patient in the decision-making process. But I think if you are going to, you got to kind of commit, because if you're going to resect it, then you need to resect it with the aim of getting it all out and not just, let's just see what it is, because then you're going to cause more probably difficulties further down the line than not. So I think doing a biopsy on it, remember it is subepithelial, so but they tend to not be deep, so you may or may not get your answer with the standard biopsy, and that's where the problem comes in. If you do a biopsy and you just have mucosa, then you might have a bit of an issue there getting your diagnosis. So not an easy one in your elderly patient with comorbidities, and chances are it's going to be an incidental finding when you find it in those patients. But yeah, most of them, by and large, the small ones, they don't produce, or they're not functional, they don't secrete. And so
Yes,
you don't need to do your 5-hydroxyindoleacetic acid on your urines and your chromogranins and all of that. And unless I think being driven by symptoms is good enough if it's under 10 millimeters. But again, do accurately measure them, because guesstimating can also get land you in a bit of trouble.
that's great.
Any
Sure,
other
any other questions floating around?
Any other comments or questions from the chat? Have you experienced carcinoid heart disease with gut nets? Never from my side. I don't know if anyone else has.
I think most of the carcinoids that I've been involved with are essentially small bowel and a very odd one in the proximal jejunum, but probably you can count them on about 3 hands.
Yeah, and don't forget the other place as well is terminal ileum. You can sometimes get these lesions in the terminal ileum, and that can also catch you out and be an unexpected finding. So it's very rare to have these secretory ones with carcinoid syndrome, and those ones are going to be larger and probably be a bit more obvious. It's unlikely that it's going to be these less than 10 millimeter ones that are functional and producing symptomatology. So by and large, it's going to be incidental findings. Any other comments? Anyone want to unmute and ask or say anything? Okay, so I think, Prof, the essence of this talk or this session was that it's something that has come up from time to time, and every now and then, in the interest group, you get a question or you get one of these cases come up. Like I said, I've actually had 2 of them in the last 2 months, so I don't think they're as uncommon as we think they are. And the idea of this was just to create awareness and to keep it on your differential diagnosis, to suspect it, and not just to say, what is that? Let's just biopsy it and see. If you suspect it, it's all in. So if you suspect it, you need to go in with the aim of getting a complete resection, because you can cure these patients. They don't need follow-up. They don't need imaging. They don't essentially need nothing afterwards if you get margins in your resection. But if you don't suspect it, that's where the problem comes in. So even if you suspect it and send it on to someone else, you can cure these lesions and not overburden your services in these patients. So that's really the crux of it, and the take-home message. Prof. Cassanides, do you have any comments or anything to add to that?
No, excellent. Yeah, I think you're right. I mean, in 30 years, my rate of pickup in the last third of my career has been much more than earlier. High index of suspicion, absolute necessity. But otherwise, excellent. Thank you. Nothing much to add.
Okay, so if that's it, I think we can close on that note. So all that's left to do is to thank the speakers. Thanks, Aslam, for that overview.
Thanks,
And
Akash.
I think that algorithm is something that's very useful, and I think that is essentially quite useful to clinicians to guide management. So if you take nothing away, that algorithm is probably the thing to take away from it, and recognizing these lesions. Then thank you again to Echo University of New Mexico, as well as the Echo India team. Remember that the recordings are available on the Gastro Foundation website. Thanks again to Prof. Cassanides and all of the work that is done with the Gastro Foundation to make these meetings possible. Thank you to all of the sponsors. You saw a whole list of them on the banner. And we kick off again next week with an upper GI endoscopy session. So more endoscopy next week. So join in for that. And Have a good public holiday to everyone, and we'll see you guys next week.
Thank you very much. Thanks to the
Thank
presenter.
you.
Thoroughly
Thanks,
enjoyed.
Andy. Thanks. Excellent. Thanks, presenters. Yeah.